Thank you so much for inviting me, and I'm excited to be here to talk with you today about the human side of addressing social determinants of health. So the objectives for today, my goal really focuses on just discussing social determinants of health. So we have a conceptualization of what this means. I also want to discuss strategies for addressing SDOH in patient care with a focus on empathy and communication. I always like to get started with this discussion talking about the definition of social determinants of health, but I also want to gauge from the audience how many people have heard of the term and feel like they have a good understanding of what SDOH means. Maybe raise of hands. Okay, perfect. So it feels like about maybe 15% of people have a good understanding of SDOH. And so with that being said, I'm going to really go through all of these areas and make sure that I provide some examples of what each of these domains mean in patient care. So the social determinants of health, it really means that they're non-medical conditions, social factors that influence health and well-being. And when I say health, I'm talking about behavioral health as well as physical health. When I say non-medical factors, these are modifiable factors. And this is why social determinants of health are so important for us to address, because they are actually things that can be addressed. If you think about these domains, right, these are 5 domains that the Healthy People framework outlines. Also, the World Health Organization uses a similar framework, as well as the CDC. These domains sometimes are broken into 8 domains or even 10 domains. I like to use the 5 because I like the simplicity of this image from the CDC. The social determinants of health are conditions in which you are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes. I always tell people that the social determinants of health, addressing it is a social justice issue because it is modifiable, and the root cause is systemic racism. If you think about things like education, access, and quality, you can think about things like redlining, why some people have access to quality education and why others do not. If you think about healthcare and quality healthcare, if you think about the idea of public health insurance, right, and the opportunities that that provides you versus private health insurance. Neighborhood and built environment, I've already talked about redlining, but that has a historical context that leads into present day right now. You can probably tell me neighborhoods in your area that are segregated. You know, one area of town is this and one area of town is that, right? And so that history of segregation and redlining, in some areas having resources and others not having as many resources, is based in systemic racism. Social and community context is important as well, and it talks about social support, cohesion, as well as things like discrimination and incarceration. That is all within that domain of social and community context. I often talk about economic stability. We're probably very familiar with this domain, things like food insecurity, housing insecurity, employment. And as you can see, within those domains, these things are not inherently negative or positive. It's the lack of resources and the lack of power within these domains that make it adverse, right? So if I have access to high quality education, then it's not negative, right? It's a positive thing for me. But if I don't have access to high quality education, then it's adverse and it can impact my overall well-being. So now that we have a definition, I want to note that this challenge is very well known to healthcare providers, healthcare industry, as well as the federal government, along with other entities as well. The important thing to know about this particular slide is that this is based on the Healthy People agenda, which focuses on setting measurable goals for 10 years to impact health equity. The very first discussion on Healthy People was back in 1979 with the Surgeon General report. And it's not necessary to really get into the full report, but the idea was that they did this scoping review of what's happening with the healthcare of society, of U.S. citizens. And they came up with these measurable overarching goals to address health and well-being. I want to say the first, and I'll look at this just to make sure, but the first healthy people, and so this has been happening for 4 decades, but the first Healthy People initiative that really focused on eliminating health disparities was in 2010. In 2020, health equity and social determinants of health domains were named directly. And in August 2020, the 2030 Healthy Initiative was launched, and it really emphasized social determinants of health, health literacy, and well-being. So on the slide, you can see that the Healthy People agenda is really set through collaboration, as well as consultation with stakeholders, individuals, communities, families, as well as government agencies, community-based organizations. It's a collaborative effort that's pulled together by the federal government. And oftentimes when I talk to people, they'll say, well, that framework is great, but what does this have to do with the work that I do on a day-to-day basis? And I'll say that the Healthy People agenda is really crucial in shaping funding for public health programs, as well as grantors. So many of your programs, many of the agencies that you work for are probably aligned with the Healthy People agenda because that's where part of the funding might come from. My work, the next couple of slides are going to get into my work specifically with college students, but it's another opportunity to look at how the Healthy People initiative is the grounding framework for the work that I do with social determinants of health. So next, I will speak briefly on 3 research projects. The first 2 studies one study focuses on anxiety and the other one focuses on depression. And I'm talking about the studies that were before the pandemic because the studies after the pandemic, of course, look a little bit differently. But I want you to pay attention to the numbers in terms of how many people presented with anxiety, how many people presented with depression, and keeping in mind that this is before the pandemic. So there's also the third study. It focuses on developing and validating a scale to assess provider SDOH competence. And that really moves us into the discussion about how to address social determinants of health. So this first study focuses on physical health and depression outcomes related to social determinants of health needs from college students. The study had 303 college students in a southeastern public university. One of the things that I like to talk about is the measures that we use to measure depression. And for this, we use the PHQ-9 to measure depression. It's a quick measure. It's a validated measure with that population. We also use the TLSC, which is the life screen measure to measure social determinants of health with college students. It's a social determinants of health assessment that is specifically used for college students. It's published in the Journal of American College Health. I'm the first author of it, so if you were interested in finding it, it's Johnson, Brookover, 2021, I believe. One of the key things that I like to point out about this research study on social determinants of health in college students is that 37% of the variance found in people who said they had depression based on the PHQ-9, 37% of the variance was because of social determinants of health needs, unmet social determinants of health needs. And to me, that is a large number, considering the fact that some counseling centers, some counseling agencies, college counseling centers as well, may not even ask a social determinants of health question, may not include a social determinants of health questionnaire. But 37% of why someone is saying they have depression is related to these unmet SDOH needs. For me, it was mind-blowing to me to have that high of a percentage. I knew that there was going to be a correlation because of previous research, but I wasn't aware that it might be 37%. Oftentimes, when I talk about this particular research study, I like to think about the impact depression has on all of these other factors within someone's life, right? Academic achievement, ability, social bonds and connections, functionality. And so 37% of the variance is because of things that are modifiable. Food insecurity, transportation issues, housing insecurity, social support, safety on campus, feeling safe on campus, having more than 3 friends in college, things of that nature. So one of the things that we used to discuss is that we may be treating depression with cognitive behavior therapy, and we may not be seeing changes as quickly as we thought, right? We have 8 sessions and we're not seeing changes. Perhaps we're not seeing changes because we're not addressing that 37%. We're not addressing the food insecurity. We're not addressing the basic needs. This is why, for me, addressing social determinants of health is just so important. We had another study on anxiety. Again, this is before the pandemic. We used the GAD, it's a generalized anxiety disorder assessment. It's a validated assessment with college students as well as adults in general. And we used the TLC again for measuring social determinants of health. One thing interesting about this is that 63% of the college students in this particular sample met the criteria for a clinical diagnosis of anxiety. And I thought 63% is a lot. Like that is very high for people just to be functioning with a level of anxiety. And I would ask you all what you think about how many people were saying that they're actually under treatment at that time. Do you think it was more than 50% of people who said that they had anxiety? I see heads shaking. No. And even going further than that, if you think about the reasons why people said they weren't under treatment for anxiety, it does not work, it wasn't helping me, there was no point. What if it's because we weren't thinking about some of these underlying causes of anxiety? And I'll tell you, I was not thinking that food insecurity would be one of the major underlying causes of anxiety amongst college students in my sample. I thought for sure I would know it would be, social support. I thought for sure it would be friends on campus. I thought for sure it would be safety. And it was food insecurity. College students who experienced food insecurity were 7 times more likely to experience symptoms of anxiety than those who did not report food insecurity. And that's huge. To me, that finding in itself, it made me start thinking about policy implications and things that we need to change systemically within the college campus to address an issue that's modifiable. And when I say it's modifiable, there is food everywhere on campus. And I'm sure tons of it gets thrown away. So there's an easy solution to addressing food insecurity on a college campus. One of the things that we talk about when we think about anxiety specifically is that oftentimes anxiety can be on a continuum, right? It may be a bit of anxiety, it may be a bit of depression, and people often might conceptualize that on a continuum. So it was very difficult for us to parse apart what is anxiety, what is depression. But one of the interesting findings was that the pieces that were important within the anxiety study were not necessarily the same things that were important within the depression study. So food insecurity, 7 times more likely to experience symptoms of anxiety, was higher in the anxiety study than it was in the depression study. So food insecurity was important in the depression study, but it wasn't as high as it was in this study here. We tried to think about what are the reasons why food insecurity might be so important in causing, more anxiety than anything else. And then we started to think about the ways in which people collaborate, the ways in which people socialize on a college campus, or just adults in general. Typically, if someone's inviting you out, they're inviting you out to have coffee or food. If you're not able to afford that coffee and food, there might be a level of anxiety that starts to happen, right? And so what starts to happen when you can't afford the food or you can't afford to go out to have dinner or lunch with someone, with a friend? Then you start to isolate yourself. You start to pull back a little bit more. And so this cycle is what we are thinking is causing a level of anxiety to increase. The other piece that was important here was the lack of social support, as well as the lack of social support was important here, as well as hazardous housing, which was another indicator that was surprising to us. It wasn't housing instability, but it was actual housing hazards. So having mold in my house, having appliances that do not work, having no running water, things of that nature, or having bugs in the house was a big one as well. And we thought, okay, so why would that be, causing anxiety? Well, if someone wants to stop over your house, you have to continuously, if you feel like you have a hazardous house situation, you have to continuously make reasons why people cannot come over. So again, it's that cycle of isolation that starts to happen. So the purpose of the 2 research studies that I just discussed were to understand students' social determinants of health needs so that we could inform university policy. That was the main point for us. We wanted to we knew that this was important, but we needed the data to show the correlation between these mental health challenges with social determinants of health challenges that impact academic achievement and things that universities are concerned with. And so assessing and addressing SDOH we knew was important, but we needed the data so that we could communicate to the stakeholders that this was an important thing to address. So using data was a part of our advocacy strategy. So I pose a question to you, and it's, how are you currently using data to address social determinants of health? And people in the audience mentioned, some people raised their hands and said, yes, I'm aware of SDOH. And some people were not aware of social determinants of health. But I want you all to be thinking about the questions that you can ask yourself around the ways in which you're using data for yourself, but also for your agency as well. Collecting data is truly important, not only for our grantors and for research, but it's also important for identifying vulnerable populations. It's important for informing strategies for improving health, developing policies and procedures and solutions, and also tracking our progress towards health equity. One of the things that we talk about when we do trainings on SDOH with community-based health centers is that the use of data is not only for our grantors to show like our progress, but it's also for developing kind of community initiatives as well. It helps us hone in on the strategies and the techniques that we're going to use when we're assessing people in practice, but it also helps us develop universal programming that we may not need to do like individual programming. If I know 80% of the people who come to my facility are struggling with food insecurity, then I don't need to ask that question anymore. But what I can do is have food vouchers available, have a food pantry available where people can grab food if they want. So because it's a universal strategy, right, instead of an individual strategy. And that's one example I like to use because we did another study, and I don't have it up here to discuss it. I don't have it up here because it focuses on professional school counselors. But one of the professional school counselors in that study, they actually started a food pantry within the school, and they expanded that food pantry to a clothing pantry. They extended that clothing pantry into a toiletry pantry, and kids were able to go in there at any point in time and grab whatever they needed. And when talking with this person, asking them, where did that come from? And the simple answer was the kids kept coming to my office saying they were hungry. And that is a community solution and not an individual solution. It's not Johnny came to my office and said he was hungry, and I gave him a bar, and it sent them on their way. It's multiple children kept coming and saying they're hungry. And so a community solution for that is a food pantry. And we can start to use data so that we can develop these community solutions for ourselves. And it also helps move us to community collaborations that we need. So as we start to, and I started to shift the conversation already towards addressing social determinants of health, I want to continue this shift by, I want to introduce a study that we did. The study is published in the BMC Journal of Health Services Research in 2023, I believe. The focus was on developing a screening tool for health providers so that they can assess their own social determinants of health competency. The reason why this was so important was because of the qualitative studies that we conducted with healthcare providers on how they address social determinants of health. And oftentimes we would hear things like, I'm really not that familiar with social determinants of health. I don't know how important, it doesn't seem like it's relevant to my patients or the people that I work with. We heard things like workflow. We don't have time to squeeze it in the workflow. So a lot of different kind of things that came up. But I would often hear people tell me that they are competent. They have knowledge of social determinants of health. I heard that over and over again. I'm very knowledgeable. I've heard the term before. I know about it. And then I started to unpack what that meant. So, okay, tell me a little bit more about what you know about social determinants of health. People were able to tell me that there were non-medical factors. They were able to say things like, it's things like food insecurity or homelessness. They were able to say those things. But when I talked about how do you address it? What questionnaire do you use? There was a gap there. When I talked about how do you advocate for policy change around social determinants of health, there was a gap in that area as well. And so what I realized is that knowledge does not always equate to competence, and it doesn't always equate to action either. And what we needed was a way for people to either self-assess themselves or for healthcare systems to be able to assess their healthcare providers. And we didn't have a measure like this available. Most of the measures that are available are qualitative in nature. They ask questions, or they really focus on just knowledge. Do you understand the definition? Do you know about the Healthy People, 2020 framework? It's a knowledge assessment and not really a competence assessment. And we know from research that knowledge doesn't always equate to action. So that was the purpose behind creating this scale. In terms of theoretical alignment, the 6 dimensions of this scale are aligned with the Multicultural Counseling Competencies and the Institutes of Medicine's framework for understanding collaborative practice and patient outcomes. The theoretical foundation it shapes the dimensions, right, of the ACN. There's 6 factors representing competency. There's action, there's knowledge, there's attitudes, there's accountability, there's preparation, and there's perceptions, which really gets at biases. The 6 dimensions take a holistic perspective on competency, expanding past studies that focus exclusively on knowledge. The QR code right here takes you to the full measure where you can read all of the questions, but I'm going to go through the subscales, and I'll have a couple of sample questions there as well. So the first factor in the scale, this first subscale, action toward addressing SDOH, it assesses awareness, utilization, and integration of resources and strategies aimed at mitigating social determinants of health barriers for clients or communities. You can see some of sample questions here. I'm aware of a questionnaire I can use to screen a client for social determinants of health needs. Why this was important, and all of these questions I think are important, but why this was important was because some of the feedback that we received during the qualitative portion of discussing social determinants of health. Again, people would say, yes, I know about social determinants of health. How are you using that knowledge in practice? What questionnaire do you use? What questions do you use? And that's where there was oftentimes a gap. Using an assessment like this, you can start to break down and unpack where you need to do more professional development. And that's how we see it. It's not a punitive thing. You can't pass or fail it. It's really important for professional development. And that's how we see this scale. The next factor, the next subscale, is knowledge. So it assesses an individual's depth of understanding regarding the interplay between social determinants of health and various aspects of well-being. Again, these are just some sample questions on here, things that we found to be really important. For instance, I am knowledgeable about the relationship between social determinants of health and resiliency. I'm knowledgeable about the relationship between social determinants of health and behavioral health. This helps people understand the importance and the significance of addressing SDOH. Being knowledgeable about the definition is really good, but also being knowledgeable about how it impacts the people that you serve is even more important. And that's what this subscale gets at. The next factor, attitude toward addressing SDOH. It assesses an individual's perceptions, attitudes, and beliefs regarding their role in addressing social determinants of health within their professional practice. This one is actually really interesting too, because when you look at previous studies of healthcare providers and their attitudes towards addressing SDOH, what we see is this really simplistic cycle, right? I have a positive attitude about addressing social determinants of health. I think it's important. I think I can do it. Your behavior is different, right? Like you are actually going to be out there trying to address it, thinking about policy changes. That moves to the action part, right? You're using a scale to address SDOH. You're asking questions about SDOH. You are advocating for policy changes. You're doing that, right? And you have results. If my attitude about addressing SDOH is that it's not really my role, and we hear this a lot, it's not my role to address SDOH. There's no way I can fit it in my schedule. I can't fit it in my workflow. It's impossible to do it. It's so big. It's impossible to even think about it. What do you think that means for the behavior?
It's going to increase. It's going to be bad. It's going to be negative.
Exactly.
Behavior goes off the charts.
The whole cycle is negative, right? And it starts from that attitude. If my attitude is that there's no way I can address this at all, I'm either going to ignore it completely, even if you bring it up. Yeah, I'm struggling with some food challenges. I live in a food desert. There's no healthy foods near me. Thank you for telling me about that. So we're going to keep moving on to the next topic, right? You just ignore it completely because my whole attitude is that there's no way I can do it. There's no way I can address this. And so that really does affect behavior. One of the studies I've read from medical health care providers, And I'll never forget this quote. It was like a provider, and he said, social determinants of health impact, I think, 50% of the health outcomes of people in my practice. And I was like, wow, that's major. And then I read the next sentence, and it said, but there's no way I can fit that into my workflow. I was like, how is that even possible? Like, I don't know if that number is true for his practice or not, but the idea that he thought that over half of the people are impacted by SDOH and the results are impacted by SDOH, and not finding the space to fit addressing SDOH into practice just doesn't make sense. Because then we're doing things, we're putting Band-Aids on things, we're putting Band-Aids on cuts, we're putting Band-Aids on things that are not even there, when we really should be addressing the elephant in the room, the basic needs. So we have to think about ways in which we can do this effectively within our practice, because workflow is a real issue. Another study, where was it, out of Maryland, it was a MedStar hospital in Maryland, and they started thinking, okay, we have to address social determinants of health. One of the things that they did was they used medical assistants to help connect people. They used community-based health workers to help connect people to resources in the community. They also said it did increase the workflow. So that it's not like there's no way to impact workflow. You don't get more time in the day, but it's so important that it's worth it to increase the workflow by 10 minutes or 5 minutes. Systemic accountability, it really assesses an individual's recognition of systemic factors that contribute to adverse social determinants of health. Some of the things that we heard as we were thinking during the qualitative portion was that some people are lazy. That's why SDOH impacts them. People don't want help. That's why SDOH impacts them. You could probably start to feel that some of the biases that people may have are starting to come out in the responses. What I wanted to make sure is that we had a piece in here that helps people think about the systemic reasons why SDOH may be impacting people's lives. So the shortage of government assistance is a cause of adverse social determinants of health. And that piece alone, right, the way people respond to it from 1 to 5 with highly disagree to highly agree really shares a lot about where we are, right? Because I actually believe that there's a shortage of government assistance, and that is the cause of adverse social determinants of health issues. You know, I can remember I was volunteering when I lived in Chicago for a very brief point in time. I was volunteering at a school, and they noticed that my stomach was growing and growing, and they said, "Are you pregnant?" And I said, "Yes, I am. You know, me and my husband were expecting a baby." And they said, "Oh, gosh, we didn't know that. If we would have known, we would have said, you can't volunteer here." And I thought, well, I was a school counselor. I'm good to go. And they said, "Oh, no, it's not because of that. It's because of the mold." Well, if it's too moldy for me, then it's probably not good for the kids either. None of us should probably be here right now, right? And they say, "Oh yeah, but specifically for you, because you're, expecting, you should not, because it's very, black mold is dangerous." I know that is very dangerous, and I'm troubled that it's in the school and we're not doing anything. And they said, it's the resources. We don't have the money for that right now. We are worried about the heat. You see how you're wearing your coat inside? It's because the heat's not working right now. And that's the next thing on the list to get fixed. And so that's government assistance. That's the federal government, right? The idea that schools are funded through like zip codes, that right there puts some schools at a disadvantage than other schools. The other thing was unequal educational opportunities is a cause of adverse social determinants of health. This question, I'll tell you that a lot of people do not agree with this question, right? Oftentimes you'll see it on the lower end. It'll be scaled at like a 1 or a 2, where people do not agree with this. If you think about some of the write-in things like everyone has access to education. Education is free, it's public, it's open to everybody. And while this is true, we know that the quality of education is different in different places, right? And people have discussions like this every day in their own circles of, oh, don't move there, move here. This is a good place to live. You have young kids, you should probably move here. They have better schools here. That is us saying that we recognize that there's unequal education opportunities. The perception of the cause of SDOH, again, this was trying to get at some of these underlying biases that people sometimes have. So it assesses the understanding of how SDOH contribute to social and economic disparities, affecting individuals' access to resources and opportunities, as well as their overall well-being. Again, this scale actually was longer, but in the validation process, several of the items did not fit within the scale. And I think that these two questions represent the perceptions very well in terms of like mental illness or substance abuse as a cause of adverse social terms of health, physical illness and disability as a cause of adverse social terms of health. And I believe that there are other questions about the perceptions of the causes of SDOH, things like neighborhood, where people live, is a cause of adverse social terms of health. Those questions did not make the final scale. However, I hope that these two questions do kind of think about, move us towards thinking about the perceptions. When we think about preparation, it really assesses an individual's perception of their school educational preparation to address SDOH. When I was talking to school counselors, a lot of them said, I never learned about SDOH in my counseling program. I didn't have any classes in it. I didn't take any modules in it, so I'm learning now, but I did not know about it in my counseling program, and that's very real. Even medical doctors would say, well, I didn't learn about SDOH. Depending on when you graduated, we may not have even been talking about health equity in the way that we're talking about it now. So the preparation scale is really important to think about where people are. They help them see the gaps, right? Either you had coursework or you did not have coursework. And if you didn't, it's a clue to think about what kind of professional development do I need so that I can be prepared to address SDOH. So now that we understand the impact of SDOH on mental health and the recovery process, we understand that provider SDOH competence is key in addressing SDOH in practice. And I will discuss strategies for addressing SDOH in practice, but really I focus a lot on the importance of communication and empathy, and so I'll talk about that. I'll talk through that a little bit more than some of the other strategies as well. But the main piece about addressing SDOH is that we should do it. I mean, I think at the basic level is that we should do it. We should jump in somewhere and start to do it. Whether that is, and I'll talk about this later, but whether that's asking one SDOH question, whether that's assessing your community-based organization, do you have an intake form? Like, that is just getting started. Empathy, for me, after doing research on SDOH, reading tons and tons of articles, talking to people, talking to healthcare providers, we have another study that's out right now that talk to rehabilitation providers, so people in rehab, so OT people, rehab counselors, PT. All of the same thing comes up over and over again. And the idea of important communication, empathy, being non-judgmental, those themes are oftentimes brought up when we talk about addressing SDOH. Empathy fosters a connection and allows us to build trust with our clients. And without trust, it's difficult to address SDOH. I want us to think back to the quick discussion that we had about data. And to get data on SDOH, there's one or two ways you have to do it. You essentially have to ask your clients. You have to ask them verbally, or they have to fill out an intake form to get data. And then we can use that data to then develop programming, right? If there is no trust, you don't get accurate data. If you don't get accurate data, it makes it difficult. It hinders your ability to develop these programming. It hinders your ability to advocate, develop policy changes, all of that stuff. And I'll give you a little idea, and I'll just share like one example. If I told you I'll give you one example on why sometimes we don't get accurate data from our clients if we don't start with a foundation of empathy. If I told you that one time, let's say I'm a client, and at one point in time, I told a healthcare provider that I was struggling with housing insecurity and food insecurity. And this is someone I trusted. They're my healthcare provider. I told them this information. And the healthcare provider took that information and they went and told social services. And the person at social services opened up a case because I said that, we were living in our car right now and it's kind of difficult for me to get breakfast to my children, and they eat at school and dinner is hit or miss. They opened up a case and my children got taken away. What are the odds that I'm going to tell anyone else ever again anything about my social determinants of health needs? It's zero. It's not going to happen, right? And we talk to providers, and I won't mention the actual place. It's not far from here, but we talk to providers about what can we do to intervene before we take a step that can change the direction of someone's life, right? I'm struggling with food insecurity. Can we share resources about food pantries? Can we help make the connection right then and there? Can we call over to the food pantry? Can we have a list and know what food pantries and soup kitchens are available right now? Can we, are there things that we could do to address that, right, short term? Can we then ask questions around, are you eligible for SNAP? Have you applied for SNAP? And sometimes people will say, well, I mean, I'm guessing everybody would have already applied for that. You'll be surprised. I had a client tell me 3 weeks in a row they hadn't applied yet. And I'm thinking, why not? You definitely, you will fit, you will get it. And they said, and the last time I asked, it's been 3 weeks. Why haven't you done this? And they said, every time I open it, it just seems overwhelming. And I was like, oh my goodness, yeah, duh. I should have sat down right here and did it. We should have just did it. And so those pieces, right, following up is super important. But also thinking about the ways in which you can intervene that won't have a catastrophic impact on someone's life. If we think about something like housing insecurity, for school kids, there's something called the McKinney-Vento program. And the McKinney-Vento program is a holistic program that really supports parents who are facing housing insecurity. Should we be connecting the person with the housing, if this is a child, should we be connecting them with the McKinney-Vento program coordinator at their school? Absolutely. Should we be thinking about shelters and places that they can go tonight so they won't have to be in their car? Absolutely, right? So sometimes it's diverting from the path that we had for that day. I might be wanting to talk about depression again. We wanted to bring up social support and all of these things, but maybe we have to divert a little bit so that we can address these pressing needs. So I also talk a little bit about the ways in which healthcare providers can use empathy to address SDOH. The first thing is understanding the context, so putting yourself in the client's shoes, recognizing that their health is influenced by factors beyond medical conditions, and understanding their life circumstances, such as economic stability, education, and community environment. And I tell this story, a really short one, where in college, it was just difficult sometimes, right? Like just stressed out. There's always these tests. There's always all these things. I'm taking, 18 credit hours. I'm trying to work full time. And I talked to my counselor, and they said, you should think about exercise. Like, that will help you, de-stress. And I thought, okay, yes. I can't afford to exercise. I don't have time to do it. I don't have any extra money to even do that, right? And while that is they are correct. Exercise can help with stress. Exercise can help with depression. It can help with a lot of different things. But not understanding the context and the story that I just gave you about barely making it, not having enough money to pay my tuition next semester, trying to work at night and work sometime in the daytime, randomly throughout taking all these credit hours so I can get out of here. And the solution was to exercise. And I think even that could have been a good solution if they would have even followed it up with, here's a paper where you can do some things at home. Or since you work at night, here's some things that you might be able to do. And, I worked at a rehabilitation place where I essentially just sat there at night. Everyone was asleep. So that could have been a good idea. You could do some chair yoga or do some stretches while you're at work. That was great. But the specific recommendation was joining a gym and doing some exercises, maybe getting a personal trainer to help with strength training and all of these things. And it was just so far out of the context of what I could do at that point in time. So understanding life circumstances are really important, because what does that do when you give me advice like that, or tell me or make a suggestion like that, that's so far out of the scope of what I can do or manage? It kind of shuts me down. It feels like you haven't been listening. You're really not paying attention to what's going on with me, and perhaps you can't even help me, right? And so that shuts down, and that kind of minimizes that line of communication. I think it also is related to active listening. So listening attentively to client experiences and challenges related to SDOH. Oftentimes, I talk about validating their experiences, validating their concerns. It's really important, especially when people are opening up about sensitive topics like food insecurity, trust, discrimination that they may be, facing. All of those pieces fit under SDOH, and showing empathy and validating that is really important. I had a student once tell me, one of the things that a counselor said, which was a little bit jarring for them, was that they needed to eat healthier. That was a solution, one of the things that they talked about that would help you with concentration, with studying. This is true. But perhaps the person didn't listen to where the person said that they live, right? The nearest grocery store was a bus ride away. They did not have a vehicle. It was a bus ride away. The other thing was they lived in a food desert. And this person actually lived in a rural area when they were in undergrad. So they were talking about this experience and thinking and saying that it was interesting to them that the counselor did not listen to their experience and where they lived and what they needed and how long it took them to get to school every day, and where they lived at did not have, grocery stores and things readily available. They had corner stores that had quick foods, and that's what they ate. And so the idea that the feedback is that you need to eat healthy, we have to think about what that means, right? Does a person live in a food desert? Can they afford to, eat healthily? All of those pieces. Of course, non-judgmental approach is really important. Avoid assumptions about a client situation. And, assumptions can be on the good and bad end, right? We don't want to do them, but I'll tell you, when I talk to, I think it was clinical mental health counselors as well as school counselors, they oftentimes would tell me they can tell when they need to assess somebody for social determinants of health. I don't know how they could tell that. Like, unless they were psychic, and if you are, I would say, use those psychic abilities for the lottery or something, but not to determine whether or not someone needs a SDOH assessment. Because I will tell you, working in a school and working in clinical mental health, people can hide things very, very well. And so, and you may never know that someone's dealing with housing insecurity or food insecurity or DV or any of these pieces, right, without asking. And so oftentimes, one critical piece for this is having a universal screening tool. If you have a universal screening tool that's at your community-based practice that you give to everyone, you have no reason to worry about missing somebody who may have an SDOH challenge that they're faced with. The other piece is you're able to tell clients when people might get uneasy about having to answer these questions. Why are you asking me this? Why do I have to answer this? You could say, I ask these questions to everybody. It's a universal screening tool, I ask it to everybody. And a lot of times people will say, oh, okay, whatever. People are concerned about, what are you going to do with this stuff? They sometimes don't have a lot of trust within the healthcare industrial complex. And so people are concerned about how are you going to use this information. And by saying, I'm not targeting you, a questionnaire that we ask to everyone is really helpful. And I think is building that communication and empathy as well. Let me see here. I think the other pieces on here is collaborative problem solving. This is really important. A study actually that we were doing here at VCU, there's a questionnaire that you use, a social determinants of health questionnaire, and at the end of the questionnaire, it actually asks, do you want help with this challenge? Do you want help with any of the problems that you click yes on? And oftentimes people will say no. And when I talk about this, my student counselors will say, well, if they have issues with with these things, why would they say no? I don't know why people might say no, but it's not our right, or we don't have a reason to push it on them either, right? Collaborative problem solving is collaborating with our client, asking them what do they need help with and what do they need support with, right? And also collectively thinking about the ways and the solutions that we can address the challenges that they are identifying. And I feel like that part is important, right? Empowering people to make their own decisions on what they need help with. The other thing I will say is that, and even in our studies, we found that oftentimes people are not faced with just one SDOH challenge. It's a cumulative impact. That means there's more than one. And so if I click yes to food insecurity, housing insecurity, social support, I'm dealing with discrimination, I'm having employment challenges, that might be overwhelming. And no, maybe I don't want help with all of those things right now. Maybe it's just one thing, right? And so that's okay as well. And the collaboration piece is important. It's telling someone that I hear you, I'm also here to support you. What can I do to support you? What do I do to help? Of course, connecting clients with resources, that's going to be really big for most of us, especially if we identify as counselors. Connecting with community resources, connecting with other stakeholders is really important. And of course, advocacy. So advocating for policy changes, because SDOH is a systemic issue, right? Food insecurity is not an individual, it manifests in an individual issue, but it's a systemic issue in general. So remembering that empathy fosters trust, I think is important, and it also encourages open communication. So in the same vein as addressing SDOH, I want to talk about SDOH assessments. And on the right-hand side of the screen, these are websites that in government agencies that you can find that have support for SDOH. They have resources, they have information that you can use to become more knowledgeable, and also think about assessments that you want to incorporate into your practice. Key is that there is no one-size-fit-all approach to screening patients for social needs. You can choose a tool to conduct comprehensive social needs screening. You can choose a tool that has 15 items on it. You can choose a tool that has 4 items on it. You can, screening tools can be self-administered, it can be staff-administered. If it's gonna be self-administered, I would employ you to make sure that it's with a 4th grade reading level, so that you make sure that you're getting accurate data, right? Making sure that people can understand those questions so that data is accurate. These tools can be taken at home, they can be taken on site. Most of them are free to use. You can use verbal assessments. Sometimes I tell people, if you don't have the time or the workflow to include 15 questions, think about 3 questions that you want to incorporate and that you want to ask your clients that come through. The key is standardizing the questions, right? So if we ask some people, yes or no, do you struggle with food insecurity? And then we ask somebody else, do you eat nutritiously? And we ask somebody else, do you live in a food desert? There's no standardization there. And so it's difficult to make sense, heads or tails, out of that data. And so the key is asking the same question to everybody, and also thinking about the ways in which you can address those questions within your agency or through your collaborative relationships in the community. So there is a balance between asking a long list of SDOH questions and asking questions that are really important for the community in which you serve. Again, we talked about this community kind of a temperature check, right? It's 80% of people in my community that come to my community-based health agency struggling with food insecurity. If it's 80%, you don't even need to have that question. We know that that is a challenge that we need to address. If you think about other questions that might be important, so you might say, well, in my area, I've looked at the community statistics, and employment seems to be a challenge in my area. Well, if that is the case, then that might be a question that you might ask on the survey, right? You might ask, do you want support with employment? So thinking about the key questions that you want to ask for your group that are directly related to community-based organizations within arm's reach that you have connections with that can help you address these issues. I tell people oftentimes when we do these type of trainings that don't ask questions that if someone says yes to today, that you have no resources for, nothing to give them, because that then becomes voyeurism and is not actually trying to support and help, right? So if you ask me, do you have any problems with housing instability? I say yes, and then nothing happens. Why would I ever tell you anything else again, right? If you ask me that question, even if it's a low level of addressing, which is, handing out a paper, right, with all the resources for housing, that is the first level of addressing, right? The second level might be a warm handoff. It might be contacting a caseworker to see if there's something that we can do today about housing. Do we have a connection with the shelter? Any of those pieces. The next level might actually be calling around the shelters. If you all are in community-based health, you know that shelters get full, they don't have any beds. So giving people a list and then none of the shelters are available is not really that helpful either, right? And so constantly checking those resources as well. So assessment is actually key. So assessment for SDOH during the intake process can really be a strategy for developing a comprehensive treatment plan that takes into account SDOH needs. People often tell me, well, if I don't want to assess, how else can I address SDOH? And I tell them, you can't address SDOH without assessment. Without knowing the challenges that people are facing, how do you address it? So we can't address it without assessment. And assessment doesn't have to be convoluted. It doesn't have to be difficult. As I said before, it can look like 1 to 3 questions that you ask verbally. It can look like 1 to 3 questions that are yes or no questions that you ask on an intake form, right? It could look like that as well. There are, of course, assessments that are really, really comprehensive, like the Prepare. That one's really comprehensive. The AHN, the Accountable Health Communities, has one that's really comprehensive. But there's ones that are yes or no questions that are 10 questions, like the WellRx, right? So there are different types of assessment tools that you can use. Providing assistance. There are nationwide resources for providing assistance. Of course, I'm not talking about the assistance that's directly related to your community-based organization or the place where you work. I'm talking, these are like nationwide kind of assistance things. Has everyone heard of 211? Very good. So 211 is a great resource, and you can call it, which I love. I love the idea that it's not just telling someone to go to a website, because everyone doesn't learn the same way. Everyone doesn't take in information the same way. So 211 is really helpful because there is a website and it's a phone number you can dial, and it uses your, just like findhelp.org, it uses your zip code to help you find resources for social determinants of health challenges. And you can do this together with someone, or you can give someone this resource so that they can do this on their own. Findhelp.org is similar to 211, in which you use your zip code to find resources in your community near you based on social determinants of health issues. Findhelp.org used to be Aunt Bertha, so some of you all may have heard of Aunt Bertha before. It's now findhelp.org. The picture right here on the right, the red one, is considered a warm handoff. And I think that warm handoffs are really important. So it's not just handing someone a sheet and saying good luck, but it's also saying, here is Sandy, and Sandy's going to be able to help you work through this sheet, right? Sandy's a caseworker. Sandy's a community health worker. And I find that that level of support is really instrumental. And also, it's important to follow up. I talked to you a little bit about the 3-week, like I had a client for 3 weeks, was not able to fill out this application that I asked them to fill out for SNAP. And the follow-up was really important, because if I would have left it at the first week, I gave you the resource, I'm sure they're going to take it and complete it, and everything should be fine. If you don't follow up, then you don't know if someone still needs more support or needs help with completing an application or just navigating the website. Even for me, having gone to these websites many, many times, sometimes it's difficult to find the resources that you need, right? And so helping someone navigate through that takes 5 minutes, and it's worth it to do it. And of course, referrals. And I talk about referrals in 2 different ways. You want to refer out to community-based agencies, to places that can support your clients, but also you want to build community support. So you want to talk to churches, you want to talk to the food bank, you want to talk to the shelters, and develop relationships and connections so that you can make direct phone calls. There's one thing to give a list of housing resources, and there's another thing to be able to call Cheryl up and say, hey, Cheryl, I have someone who might need some support. Are you able to help them? Can you get on the phone call with them? And I think that makes a big difference. I have a minute. Okay. So I'm just going to skip through this because I think we only have 1 minute left, and we might need, and just in case people have questions or something along those lines. But I'll say, what's next? And I think this piece is like really important in terms of thinking about what you're going to do next, right? You have to define your goal. Do you want to start collecting data, or do you want to start learning more about SDOH? Do you want to divide your goals into milestones? So what is manageable for the first 3 months? Is it manageable for me to join a webinar about SDOH? Absolutely. Is it manageable for me to go to a conference about SDOH? Maybe not, right? So thinking about what's manageable and what you can get done, in a relatively quick time frame. Identify resources that you need to accomplish your goal. What stakeholders do you need on board? Do you need your boss on board? Do you need your supervisor on board? Do you need the community-based health agency on board? Who do you need on board in order to get these things done? And also prioritizing and assigning tasks. That's really important when you're thinking about addressing SDOH. Who is on board already? Who needs convincing? Does this make new tasks for new people, or do we have enough people so that we can address this right in-house? And then, of course, review, reflect, and refine as you go. Things can change, and it's important to be flexible. Okay, so that's all I have for you. Start where you are, use what you have, and do what you can.